Assalamu alaikum students. I am Dr. Usma Hamza. Today is our first online class. I welcome you all. Hopefully everyone is safe and healthy and maintaining social distance and following the appropriate precautions. I will continue the topic of cornea. We were discussing the corneal ulcers, and in last lecture we had discussed about the bacterial corneal ulcer. Today I will discuss with you fungal keratitis. The cause of fungal keratitis is two types of fungi. One is the yeast and other is filamentary fungi. Predisposing factors are mainly the vegetative trauma, usually in OPD, person working in the field present with history of trauma with some vegetative material or some branch of the tree or trauma with some gardening or agriculture tool. Chronic ocular surface disease is also one of the predisposing factors. Patient with contact lens wearer can also have fungal keratitis. Prolonged use of topical steroid is also one of the cause of fungal keratitis. Factor. The symptoms with fungal keratitis are gradual onset of pain. This pain is not so much severe as you will see in patients with bacterial keratitis. Patient also complaint of irritation and photophobia. There is also complaint of watery and mucopollulant discharge. So come to the clinical sign. You can see in this slide there is marked conjunctival congestion and along with there is also ciliary congestion. Cornea is not transparent. It's a hazy and edematous with central yellowish gray lesions. Other sign which you can see in fungal keratitis is this epithelial defect, and beneath the epithelial defect there is gray or yellow white stromal infiltrate with fluffy border and feather-like projections. These are feather-like projections into the normal stroma, and there are other stellate lesions also. What is stromal infiltrate? Stromal infiltrate is actually inflammatory or necrotic debris which is formed after the invasion of corneal stroma with the fungus. This inflammatory and necrotic debris which is stromal infiltrate, it have a very fluffy border with superficial dry look, and these stromal infiltrate have feather-like projection into the normal stroma of the cornea. If you see this picture, you will see here this is stromal infiltrate, grayish or whitish gray with fluffy border, and these are finger-like projections, feathery projections, and these are the stellate lesions. Also in this picture you can appreciate also the conjunctival congestion, and this is circumcorneal congestion. You can also see there is a hypopyon. Hypopyon in fungal keratitis is thick and immobile. There can be a raise in intraocular pressure as the inflammatory exudate occlude the trabecular meshwork and which leads to raise in intraocular pressure. If corneal inflammation extend to the sclera, it may cause scleritis, and if this inflammation extend the anterior chamber and involve the posterior segment, then patient can present with fungal endophthalmitis. The differential diagnosis of fungal keratitis is bacterial keratitis, herpetic keratitis, and acanthamoeba keratitis. Regarding diagnosis, we can diagnose fungal keratitis in 3 ways. We can diagnose from history of vegetative trauma, number 1. Number 2, we can diagnose from the typical clinical signs of fungal keratitis, which we have already discussed. And number 3 is the lab investigations. So in lab investigation, KOH preparation with direct microscopic evaluation is a rapid diagnostic tool with high sensitivity. We take a specimen from corneal bed and place this specimen over the KOH drop over the glass slide and then examine under the microscope. This is a very rapid diagnostic test which having a high sensitivity. The other stains which are available are gram staining, Gemsa staining and chalcofluor white stain. In addition, corneal scraping can be sent for culture. Seborrheic dextrose agar is the culture available for the diagnosis. Polymerase chain reaction PCR analysis is also a rapid and diagnostic test. In cases where there is no diagnosis is made on basis of investigation, in such cases we can take anterior chamber tap and send for culture sensitivity. We can also take corneal biopsy, a 2 to 3 millimeter block, and set for culture and sensitivity for diagnosis purpose. Come to the treatment. Hospital admission should be considered for patients who are not likely to comply, and it should also be considered for aggressive disease, particularly if involving the only eye. Contact lens should be discontinued if there is history of contact lens use, and plastic eye shield should be worn between eye drops installation if significant thinning or perforation is present. We should remove the thick epithelial plaque over the cornea, and also we have to remove the debris and mucus with spatula so that the maximum penetration of topical drops is possible. We have basically two types of treatment. One is specific, another is non-specific. Regarding specific treatment, we have topical antifungal drops, which should initially be given hourly for 48 hours and then reduce according to the sign. We have natamycin 5% eye drops or fluconazole 2% eye drops. In severe corneal ulcer, we can also add systemic antifungals, and systemic antifungals are fluconazole and ketoconazole. Regarding specific treatment of fungal keratitis, intrastomal injection of antifungal drugs can also be considered in cases where there is poor response to the topical eye drops. Regarding non-specific treatment, we have topical broad-spectrum antibiotics to cover the secondary bacterial infection. We should start topical cycloplegic eye drops. We should monitor the intraocular pressure, and if there is raised intraocular pressure, we should start topical anti-glaucoma drugs. Analgesic and anti-inflammatory can also be given to the patient if there is severe pain to the patient. Vitreous tap and intravitreal antibiotics and antifungal drugs is indicated in cases of fungal endophthalmitis. If infection spread from anterior segment into the posterior segment and leads to fungal endophthalmitis. In the last, if there is failed medical therapy or there is perforation of corneal ulcer, then the last choice is the therapeutic keratoplasty. Here I am sharing with you SCQ regarding fungal keratitis. A young farmer present in OPD with a history of trauma with a branch of tree. He complains of mild pain with irritation and watering. What is the most likely diagnosis? What is the differential diagnosis? What investigation you would like to do in this patient? And what is your treatment plan? Thank you so much.